options for dental applications. It's important for us to discuss the various radiographic options that are available for dental applications and especially implant surgical applications. There are three main options available in clinical dentistry. First and foremost, the readily accessible and standard periapical radiograph. It's readily available. It does have quite a bit of accuracy in the mesial, distal, and the height category. Although it does not give you three-dimensional views and is difficult to standardize. Periapical radiography is excellent for routine clinical implant dentistry, especially when an implant clinician feels very comfortable and has a tremendous amount of experience with surgical placement of implants. It's important to understand, though, that a periapical radiograph does have significant limitations. If the periapical radiograph is not perpendicularly placed or at a cross-section, you could have foreshortening or elongation of your radiograph, thus resulting in distortion of your desired measurement. It works really well for recent extraction socket sites and for experienced practitioners. If it's a relatively recent extraction socket site, or say it's a soon-to-be extraction socket site, it does give you a pretty good assessment. The panoramic radiograph is a very simple, whole-picture view of the entire dentition. It is a relatively common type of radiograph, especially in my clinical practice, for diagnostic purposes only. It does work especially well for implant procedures in the anterior mandible. We've been placing implants in the anterior mandible with solely using panoramic radiograph for years and years and years. It's important, though, that it does not also give you bone width, but more importantly, it gives you an unreliable level of accuracy. The reason why I say it's unreliable is because a panoramic is reconstructed based upon semicircular radiography exposures. It suffers from a dimension of something called parallax, and we'll explain more in a bit. Panoramic radiographs, again, an extremely effective way of doing mandibular anterior implant surgery. A cone beam CT scan, or a CBCT, is incredibly accurate. Roughly 1-to-1 accuracy in almost all dimensions. It does give you some additional really interesting things, such as individual slices, axial, coronal, sagittal, instantaneous slices. Additionally, it gives you relative density values. It gives you the idea of how much bone density you're going to be expecting when doing a surgical or implant procedure. Additionally, it gives you a tremendous amount of flexibility when considering using guided surgery. Some of the negatives of CBCT, of course, the number one is that it's expensive. The typical CBCT machine starts at around $70,000 brand new and goes upwards of $180,000. It does have substantially greater radiation exposure on average than the periapical or the panoramic radiograph. Now, this is debated out there just because there are so many cone beam imaging companies that do claim that their scanners have equivalent doses lower or equal to that of panoramic or periapical. But still, the general rule is there is more radiation to be concerned with. So we typically try to follow ALARA principles, or as low as reasonably acceptable principles, to minimize exposure with our patients. Many times, because of the cost, we often have to refer from our clinical practices. I do know that I have a cone beam machine in my office, and it's very difficult for me to conceptualize the thought of having to send out a patient for a cone beam scan. Why? It's because I'm so used to having it in my office, I think it's relatively invaluable for an implant practice. It does have a relatively universal application, meaning that a cone beam CT is universally acceptable for implant procedures, medical modeling, endodontic procedures, orthodontic procedures, etc., etc. The panoramic radiograph, as mentioned before, has magnification error to be considered. It's non-uniform magnification, meaning that at different time points or at different points along the x-ray, you're going to get different levels of stretching and magnification errors. So even though it might look like there's the same amount of bone in the mandibular lateral incisor position as the premolar, if the patient is not perfectly positioned, there could be a 20 to 30% magnification error. Also, you have potential linear errors of close to almost 3 millimeters. That makes a huge difference between success and failure of an implant. Of course, there are no width measurements. Only the CBCT can give you that. And then also, there is a greater variation of that magnification error in the horizontal than the vertical plane. Meaning, the traditional method of using a panoramic radiograph for implant procedures was to use these little BBs that you see on the screen in front of you. I'll point at it with my mouse right in here. The idea of these BBs is that you know that a BB is approximately 4.5 millimeters wide, so it became a calibration sphere. Any point below that sphere on the radiograph, you would have a good assessment of what your length was. A cone beam CT gives you one-to-one accuracy. It's important to understand, though, that because you have more data, that does have larger files and more detail. And I know many times it's a hotbed discussion in the world of radiography that when you do expose a patient, you have more data to interpret and more liability associated with those scans. It's important to understand that every time you scan a patient, whether it's a periapical or a panoramic or a CBCT, you are responsible for reading that information. And if you don't feel comfortable with reading that information, you are responsible to ensure that somebody does read it. Additionally, a cone beam CT relies upon resolution of a three-dimensional image. The three-dimensional image resolution is determined by individual volume elements known as voxels. As mentioned before, a cone beam CT does have a relative level of radiation exposure. I will certainly argue that it's important for you to not call this a CT scan with your patient, because many times patients are thinking of a medical grade CT. It's important to understand that they are anticipating that the average x-ray is what they're used to seeing in the hospital or from what their experiences have been before in the physician's offices. Those types of radiography machines do dispense a tremendous amount of radiation, especially in relation to the traditional dental films. The important thing to understand, though, is that we do have daily background radiation as well as commercial radiation in airspace. I will tell a patient all the time that the average cone beam CT is like taking an extra couple of flights per year or a walk out in the sun. Traditional methods for analyzing a case for implant dentistry is utilizing a full mouth series, proper diagnostic tools, panoramic radiography. This information is then combined with a clinical exam of the patient and potentially study models. The traditional methodology has been to use study models with diagnostic tooth arrangements, also known as wax-ups. We also know that when you look at this is the traditional model, still works and is still very appropriate in today's digital world. However, it's much more cumbersome. Taking a look at this, we know that the panoramic radiograph does have its limitations. You can see here that this is a wonderful example of when to use panoramic radiography for diagnostic assessment. This patient came to me with the idea that he would like to have implants placed to help hold his lower denture in place. We made this panoramic radiograph and we made the assessment based upon not only the pano, but the clinical data that he would be an excellent patient to use strictly for panoramic radiography. Why? He's a recent extraction socket case. We know that if we did a pretty good job of extracting those teeth, we would have sufficient bone width and volume there. Now, just as a corollary, in my own clinical practice, most of my patients we use CBCT radiography. Even though he would have been a good candidate for a standard panoramic radiography treatment plan without a CBCT, I do believe in the use of CBCT because it's important to take a look at all the dimensions of the bone. We know that this patient gives me a chance to see the bone in 3 dimensions, looking at all of the contours associated with the jawbone. The individual slices allow us to plan appropriately here. This is an example of a patient who is a seemingly good panoramic treatment planning case. Take a look at the left-hand side of the screen. It almost looks like this patient has a ton of bone. Many times a clinician would say there's a mile of bone there. I even went ahead and utilized a gutta percha marker in the positions of where I thought the implants would go well. However, in relation to the clinical examination, you can see that the patient has significant undercuts and an extremely thin atrophic ridge. This patient we of course did make a CBCT on because we wanted to make an assessment of what this patient's bone looked like prior to elevating a flap. We can see here that if I slide that out of the way, there was significant bony undercuts on the facial and lingual. And part of the reason why I show you this is that even though on the 2-dimensional panoramic radiograph, it appeared like there was plenty of bone, if you were only utilizing a 2-dimensional film for surgical planning, you know that you probably would have gone into that surgery unprepared. Or potentially you would have gone in with what you thought was the right implant, maybe a 3.5 millimeter wide implant. Eventually I'll go ahead and find enough bone to place that implant. In this particular patient, you would have to go down almost down to here to find the proper level of bone for this implant or for this patient. So it's important. I wholly do believe that cone beam CT is my standard of care. Now, is it the standard of care? That's certainly up for debate. Cone beam CT also allows you to do some very compelling things with diagnostic tooth assessments. As mentioned before, the traditional methodology is to utilize radiography with standard dental laboratory procedures. I can tell you in my clinical practice, as a routine, I no longer wax up a tooth. Why? We saw earlier, Mesh Mixer and open source CAD software allows you to do a tremendous amount of things digitally. Also, contemporary CBCT planning software allow you to make instantaneously assessment of the tooth positions in relation to the surface rendering or the 3-dimensional scan of the patient. It's important, no matter what sort of surgical intervention we so choose to do, it's important for us to visualize the endpoint. What is our plan? Ultimately, our end plan is going to be dental teeth, a restoration, a tooth. Now, I was always told in dental school that patients come into your office saying one thing, but what they really mean is they want teeth. Well, I can tell you that in this day and age, patients come in all the time saying, you know what, doc, I want those implants. Now, of course, what they do really mean is that they really mean teeth. They want teeth on there. But patients are aware of the power of digital technology and how important implants are in the restoration of the functional dentition. Most cone beam imaging software will allow you to overlay scan files of not only tooth preparations like you see in the center part of the screen, but also a diagnostic tooth assessment, whether it's a temporary or a wax up, like you see on the right-hand side of the screen. This portion is going to be talking about how we utilize our CBCT scanner, how we position patients and understand voxel size and the field of view exposure. Let's go ahead and talk about our patient positioning and optimal resolution. We know that we can come and design multiple different types of 3D scanners in our office. The CBCT machine comes in 3 different flavors. You have the traditional sit-down machines like you see here on the left-hand side of the screen. The iCat or the Prexion unit is a very effective way of scanning a patient. It works extremely well, especially for holding a patient perfectly still. It does tend to be a little bit scary for patients when you look at that, and it does tend to be a little bit medically looking, meaning that this is something that looks a little bit cumbersome. It does take up a whole bunch of space in an operatory or in an office. However, it is my preferred method of utilizing CBCT, especially for me in my practice because I have a tremendous amount of older patients that have difficulty standing. Now, that being said, I do have in my clinical practice a standing unit right here in the center. I utilize a standing machine where a patient stands, keeps their chin in the chin cup, and then remains standing for the entire procedure. However, that being said, both of these are exceptionally good ways of obtaining a CBCT scan. The older and more traditional method of CT scanning, especially in a medical grade system, is the lay flat system, like you see here on the right with the Siemens scanner. Now, there are dental versions that still do this. You can go out and invest in a tabletop scanner like this where you actually slide the patient into the machine. Now, ultimately, that can be something also very scary for your patient, and portraying a relaxing environment is very important for you in your clinical practice. One thing I like about my scanner, like shown here in the center part of the screen, instead of making the X-ray buzzing sound, it sings a song while it scans. Really cool. Let's talk about patient positioning. It's important to understand that a patient should be positioned with their face and head in the proper positions. As you see here with these red lines, we want to line up our red lines. You have a straight midline marking that should go through the center part of the patient's face. And then also you have a Frankfurt horizontal red line that more or less aligns the patient's skull and dentition in relation to anatomical skeletal structures. It's important to ensure that your patient is aligned properly because the center part of the cone beam scan is always the most accurate. Even though cone beam CT scanning is 1-to-1 accuracy, there is some aberration that does occur on the periphery part of the scan. So anytime that I make a scan of something, especially a patient or even a dental model, I always want to have it as close to the center as possible. Meaning that if my focus is on the maxillary arch, I try to put the patient's maxillary arch right towards the center part of the cone of the scan. Now, most computer softwares allow you to reorient a patient's scan. If you notice after importing a scan into your computer software that the patient was leaning, or if your assistant did not catch that, no problem there. You can reorient your DICOM scan. Some softwares allow you to reorient it and then export it as a reoriented DICOM scan. This just happens to show you the anatomage system. The anatomage system makes it very easy to reorient scans. It's important anytime that we scan a patient that we always want to avoid patient movement. As shown here on this left-hand side of the screen, you see a double ghost image. This is the main image, patient's actual base of their mandible, but then something happened. They might have bit down a little bit or even breathed just a little bit, moving their mandible. And on the second part, as the cone beam scan went around the other edge of the screen, it just caused a second image to get superimposed over the top, called a ghost image. That would typically be a rescan in my clinical practice. Now, it's important that we also understand what background noise and scatter is. Anytime that a patient has an existing dental restoration of metallic nature, or even ceramic nature if it's dense enough, could cause a photon beam of the cone beam scanner to go ahead and bounce off of that restoration. As it hits right here, it goes bing and it flies off in a different direction. Many ways, like if you were to shine a light into a prism, it will shine multiple directions. Or better yet, the example of the disco ball. You shine a bright light into it and it flies all over the place. Let's talk about field of view. It's important that we choose the appropriate field of view for each individual patient's scan. Field of view is a very complicated matter within cone beam CT radiography because it's difficult to understand. The most important thing to understand about field of view is that it really just doesn't matter. All you want to do is that you want to choose the right field of view that's going to give you just enough exposure for what you need. So ignore all these numbers. All these cone beam companies are going to say, well, I have a 80 by 165 or a 8 by 5 or a 12 by 10. All that means nothing to me. What matters to me is what the practical application of it is. If I'm an endodontist, I can work in this type of field of view. But as a prosthodontist and implant dentist, I can't. This just doesn't make any sense whatsoever. The vast majority of the time, my scans are going to be in this medium field of view, somewhere right around like 170 by 80 millimeters. And typically, I don't even mess around with these other slices. I typically do most of my scanning in this field of view. My justification is this: even though it's slightly greater amount of radiation for a patient on average to get this scan versus say all I needed was this scan to see the maxillary arch, if I have a positioning error that results in me missing 1 out of 10 scans, 10% of the time, I have to reshoot the same picture again. So there's a chance that I could have actual greater amount of radiation by doing this one twice than this one once. Now I know that sounds kind of silly, but it's true. In an everyday clinical practice, when your patients are trusting in you and having you go into a cone beam scanner and scanning you, they expect that you do it right the first time. I don't mind having a slightly larger amount of field of view to ensure that I properly capture all the data. The important thing is that we have to make sure that we weigh that. And typically most implant scans are somewhere in this range, medium field of view. Now, many times this is not even something that you can control because it's limited by your CBCT machine, meaning that my wife as the orthodontist would love to be able to scan our patients in this type of field of view or this type of field of view. But most CBCT scanners don't scan in that field of view because this one's typically rated only for orthodontists. Now, the field of view selection is made within your CBCT acquisition software. This just happens to show you the acquisition software that I use in my cone beam scanner. As mentioned before, most of the time I use this field of view right here just because it picks up the maxillary and mandibular arches at the same time. However, if I wanted to, I do have a tiny field of view just to capture right in here. If I wanted to get the left central incisor, there is the settings within the software to do that. Now, as we select that field of view, it'll change the dialog box, allowing us to see the amount of exposure. I really like this acquisition software because I just really don't care about the numbers, the sizes that are here, because it gets confusing. All I care about is as a dentist, I'm a pretty visual person, so I want to see what this exposure is. Now, anytime that we look at field of view, we have to be concerned about capturing the proper amount of structures. Now, shown here on the left-hand side of the screen is my CBCT machine and the field of view. And shown here on the right-hand side of the screen is a university-based CBCT machine, something that has a much greater field of view. Now, I certainly will argue that the right-hand side of the screen is really nice just because it's so easy every time. I do feel that that's an excessive amount of exposure for a patient, where the one on the left-hand side of the screen is more than enough for 98% of implant procedures and surgical procedures for me in my clinical practice, if not 100%. What is a voxel? A voxel is essentially a three-dimensional pixel. We're familiar with what pixels are. When we choose our phone, we choose a computer, an LCD screen for our home above our mantle, we know that things are typically rated in pixels. My computer screen, 1980 pixels, etc., etc. The retina screen on your MacBook, certain amount of pixels. Now, a pixel is a square. It's a two-dimensional square that projects an image. If you zoom in close enough in Photoshop or on an image, you'll know that everything that's on your computer screen is a reconstruction of little tiny squares. Since we have higher resolution with a higher pixel density, it just means that it takes more squares to color the same amount of object as a lower resolution scan does in the same space. The same thing is true in three-dimensional imaging. Three-dimensional imaging is the three-dimensional squares. Now, of course, anytime you take a square and you turn it into three dimensionals, it's essentially a cube. Squares that are equally sized all the way around. Since we now have cubes, we can reconstruct a three-dimensional object by stacking those individual cubes on top of each other. And the same is true in dental imaging. Optical scanning, instead of using cubes, it uses triangles, but it works in a very similar fashion. The cone beam scanner does use individual squares or cubes known as voxels. A voxel is a reconstructed three-dimensional cube. Anytime that you have an increased cube size, just like the increased pixel size, you have lower resolution. The smaller the cube is, the same object is imaged, it requires more cubes to image that object. So typically, a very high resolution CBCT scan has a cube size, or the wall of the size, as 0.2 millimeters, meaning that the side of the cube, or the square component, is 0.2 millimeters height and wide. A high resolution scan is 0.3 millimeters. That's what I would consider a high resolution scan. A normal resolution scan is 0.4 millimeters. Some would consider this a lower resolution scan, and the 0.3 is the normal. However, I disagree with that. The reason is that some cone beam scanners allow you to be an extremely low resolution, 0.5 millimeters or less. Now, or greater I should say. Now it's important to understand that if you reconstruct an image and you have a cube, every side is that distance measurement, high and wide. Anytime that you jump up in resolution, you change the resolution by a cube, or by a cubed by a third, raised to a third, I should say. It does dramatically affect your resolution. So even though it wouldn't necessarily seem that much smaller, 0.3 versus 0.4, you have to times it by 3 or cube it. Voxel size is chosen within your acquisition software. So after I choose my field of view, it gives me the option of being able to choose voxel size. Some softwares will say low resolution, medium resolution, high resolution. My software says small, medium, or large. Large is the normal resolution, medium is the high resolution, and small is the very high resolution. The software automatically adjusts the scan time and changes the settings that correspond with your selection. How a scanner achieves a 0.2 versus 0.4 millimeter voxel size is that it's dependent upon the amount of exposure on a patient. The larger the voxel size, the less time required for a scan. The smaller the voxel size, the more time required for the scan. Why is that? You're scanning the same object, your patient. If you want a higher resolution image, you need more radiation exposure to capture the detail. When it does that, it requires more time to expose the radiation, hence a longer scan time. Most of the time in my clinical practice, I utilize a 0.3 or 0.4 millimeter voxel size resolution. I typically recommend this. I find that it's benefited because typically the 0.4 millimeter resolution results in a pretty good clean scan. Additionally, I would love to be able to scan every patient at a super high resolution, but part of me says that that's not necessary just because it's going to expose your patient to more radiation. Additionally, anytime that you have a longer scan time, you increase the chance of artifacts and movement on your CBCT. So if it takes a significantly longer time to scan a patient, the same patient, and your patient is standing the entire time, maybe has weak knees or maybe needs to breathe, there's a chance that you could have movement on your scan. That would necessitate starting all over again. So I recommend 0.3 or 0.4 millimeters resolution. Now, anytime that you cone beam scan an inanimate object, such as a denture or a dental model or dental impression, I recommend the highest resolution scan. Why? Because your patient no longer is moving and you're scanning an inanimate object. It's important here just because we have the ability to be able to scan in super high resolution. Now again, as mentioned before, voxel size is dependent upon scan and exposure time. As shown here on the left and on the right, this is a patient that my assistant accidentally scanned on a medium resolution. The medium resolution, or the higher resolution I should say, the higher resolution 0.3 millimeter voxel size resulted in my patients moving ever so slightly on the right hand side of the screen, or on his patient's right. So we're imaging for the implant at the number 30 position, and it resulted in movement. So the patient was biting on some cotton rolls and had to take a breath, or the mandible moved ever so slight, caused just enough movement for the radiation and for the radiography to not be effective. We remade the scan at the normal resolution, the 0.4 millimeter voxel size, and it resulted in a very nice clean scan. One thing I do like to know about CBCT radiography is that any time that I make a scan of a patient, I typically want to keep their teeth separated from each other and also to separate the soft tissue. The vast majority of the time in my implant practice, I don't particularly care where the lip is or where the tongue is. If you're an orthodontist, it might be important for you to be able to see where the lip and the tongue positions are. But in an implant practice, those just get in the way. I find it's much easier to see all of the detail of the patient's bone volume if I don't have the teeth in the way and if I push the cheeks out of the way. Some things also we want to talk about are things like single and dual scan. A traditional dental x-ray for CBCT is the single scan approach, meaning you want an image for a patient. Patient is missing tooth number 13. You send the patient for a CBCT scan, either in your office or at a scan center. It comes back, patient was scanned once. You can see the bone width, the bone volume. Everything is done just in a single scan. Nothing fancy, keep it simple. This is very effective for medical modeling. If I wanted to extract an image or a model from a patient's CBCT scan, all you need is a single scan. The dual scan protocol is a contemporary scanning method. It is essentially taking multiple scans and joining them together. Anytime that we can take two scans, whether it's two cone beam scans or one cone beam scan and an intraoral or desktop optical scan, we can go ahead and increase our visual planning by stitching the two together. When I stitch the two together, it enhances the visual of the plan. Additionally, it allows us to do guided surgery applications. The single scan is really only for visual assessment and for planning implants only. And certainly you cannot do guided surgery with a single scan only. The dual scan protocol is certainly more complex. Anytime that you have to join multiple scans together can potentially result in minor errors and complexity as a result. And certainly it's more expensive if you're outsourcing your CBCT. Most scanning and imaging companies do charge per scan. The dual scan protocol also allows you to join scans together using similar marking systems. This is an example of utilizing a fiduciary marker, also known as a gutta-percha point. This patient was scanned wearing an appliance, and in the appliance there were some markers that show up bright on an X-ray. When the patient is scanned wearing the appliance, then the appliance is removed, and the appliance alone is scanned in the CBCT. It can result in the CBCT machine joining the two together and segmenting out the difference, meaning allows you to visually see these two independently, even on the patient scan. During the visualization of the process allows you to instantly plan, as well as come up with guided surgery applications. Let's spend some time talking about soft tissue isolation in a CBCT scan. As mentioned before, I prefer to use soft tissue separation to enhance the visualization of our anatomical structures, including our bone volume and dentition and soft tissues around the teeth. This allows me to instantaneously see all of the structures, even when there are restorations that can get in the way and cause background radiation scatter. By separating the dentition, it allows me to instantly see the occlusal surfaces of the dentition. And the cotton roll separation, or the soft tissue separation, allows me to then visually see the patient's skin and tone in 3 dimensions. By doing that, we can then go into individual slices and being able to see the patient's soft tissue as a separate feature from their hard tissue. Now, it was always told to me that CBCT only works for scanning hard tissue, but it works extremely well at scanning soft tissue as well. By doing this approach, by gently separating the soft tissues, it gives us a much clearer visualization of the dental structures. This will enhance our implant planning and make things much easier, simpler, faster, and have better visualization. We recommend a multitude of different methods for soft tissue separation. In collaboration with a colleague of mine, Dr. Rowe, we advocate utilizing soft tissue separation techniques. Typically, this is done with one of 2 methods: cotton rolls or some sort of cheek retractor. Additionally, you can use a tongue depressor to help separate the occlusal surfaces from each other. This is showing you using an automatic plastic cheek retractor that has like a spring-loaded function. You can scan a patient wearing this in their mouth with a couple of cotton rolls on the lingual surface and a stick to bite down on. The stick to bite down on will greatly enhance the patient's scan. Most of the time, however, in my clinical practice, I use just cotton rolls to separate the dentition. It's much simpler and faster. My preferred method in my clinical practice is to use an obturate. I use an obturate to slide in between the lips and the dental structures, and then I have my patient bite down on 2 cotton rolls. If I'm scanning for either the maxillary or mandibular arch, this gives me an extremely good soft tissue separation without me having to do anything too complex. In this clinical demonstration video, I'm going to be describing how to properly isolate the soft tissues around my patient's dentition. I'm going to start out with a series of cotton rolls. This first video is going to show you isolation for our dental implant site on the maxilla. For a maxillary arch only, I'm placing a total of 5 cotton rolls. 3 on the buccal and 2 on the occlusal. The 3 on the buccal correspond to roughly the upper right, upper left, and upper anterior portions. The 2 cotton rolls for the biting surface are to separate the maxillary and mandibular dentition during the scan. Viewing at it from the occlusal direction, gently separating the soft tissues. For our mandibular example, I utilize a total of 7 cotton rolls. 2 on the lingual, 3 on the buccal, just like the maxilla, and 2 on the occlusal surfaces. Essentially, it's the same technique as you would use on the maxillary arch, except that you add 2 additional cotton rolls to help retract the tongue away from the lingual surfaces of the mandibular dentition. An occlusal view shows that it's actually very simple to do. To do maxillary and mandibular arches together, I prepare the mandibular arch completely, have the patient occlude, and then place the 3 maxillary cotton rolls once everything has been occluded. Starting with the upper left, upper right, and then upper anterior. Once I place all the cotton rolls, I ensure that all the soft tissues are tucked in around the cotton rolls and there's no area of contact. Using the Optrogate technique, I'm going to remove the Optrogate from the package, spray it down with a little bit of air and water from my dental unit, as shown here. Lightly moistening the outside portion of the Optrogate. I'm going to be pinching from the sides and from the superior and inferior portion at the same time, placing just past the incisal and occlusal surfaces of the dentition, having the patient curl their lips in lightly. Once the Optrogate is in place, I then take just 2 cotton rolls and have the patient occlude gently onto the cotton rolls. This makes for very simple soft tissue separation. In this clinical video, taking my patient from the operatory into the cone beam CT room. My patient already has the soft tissue separation in place, whether the Optrogate or the cotton rolls. I'm going to be putting a shield over the top of my patient before I do any scan. Now in my software system, I'm going to activate the scanner, ensure all the settings are correct, and it's going to go through an initial setting, recalibration, and initialization. As it does it, my patient is standing by, typically behind the scanner. Now it might look like they're very close together in this video. However, there's a good considerable distance between my patient and where the scanner is turning. Older patients can be sitting down while we're doing this. It usually takes about a minute or so for the scanner to calibrate and to initialize. Once completed, the scanner will say that it's ready. I have my patient walk forward, grab the handles, and position his chin on the chin cup. The red lines for the allotragus and midline are going to be appearing in front of you. As I take the patient, gently ask him to step forward and to rest his chin on the chin cup. I'm going to be positioning his head, shoulders, and the rest of his body within the parameters of the CBCT machine requirements. I like to ensure that that horizontal red line is in line with the goal of what I want to scan. Typically that's the center of where the cone beam scan will be. Once completed, the scanner is going to do a second initialization, and then I activate the CBCT scan. Typically it's activated with a push button assembly, either on the outside portion on the wall or with a retractable cord. Typically cone beams will take approximately anywhere between 15 and 45 seconds to expose a patient, depending upon voxel resolution. The cone beam machine will tell me when the scan is complete. Then I can go ahead and step back into the operatory. Ask my patient to wait until it's done spinning, and then have the patient carefully step back away from the unit, remove the lead shield, and then I have a chair waiting for him. At this point, I can ask my patient to spit out their cotton rolls. I prefer the patient to do this, it's more comfortable for them and then I ask my patient to go back to the operatory with my assistant. The cone beam software is going to reconstruct the DICOM files and convert them over into individual DICOM slices. Once I've had a chance to finish the software interpretation, it pops up asking me to check everything. I always go through each individual slice to look for artifacts, movement, or any errors. Once satisfied, I can click the OK button to save the images. Now that my DICOM images have been converted over, I can open those files within the proprietary software built into my cone beam scanner to analyze them. Within this software, you can do a variety of different things with it, but principally my main interest is just to triple check the scan and then to export the DICOMs. This particular software lets you export DICOMs into a folder, so I put them onto my network in a share folder for each individual patient. Alternatively, it will allow you to burn a CD-ROM disk with all the DICOM files in place. Once finished exporting, I can open up my Windows folder and verify that I have individual files, somewhere between 200 and 500 individual files, ensuring a proper capture. Files is a seemingly complex thing to do, but is actually quite simple. First, let's talk about what a DICOM file is. A DICOM file stands for a Digital Imaging and Communications in Medicine file. It's essentially a specific set of structures, contents, and materials that an organization has come together and said this is the standard that we hold all of our radiography imaging to. It's essentially a universal standard across all of medicine and dentistry. And while the information and term is copyrighted by the National Electrical Manufacturers Association, it is widely considered an open source file. A DICOM file typically has an extension of .dcm. Sometimes these files won't have an extension name on the files. Especially if you're a Mac user, many times you don't see the .dcm after there. Each individual DCM file is a X-ray slice. As you know, a CBCT takes individual slices of radiography files and reconstructs it into 3D. These individual slices then are interpreted by a computer software, generating a three-dimensional image. There's typically somewhere between 200 and 600 of these individual files organized in a folder. When your acquisition computer machine for your CBCT generates a DICOM folder, it will typically do this for you. There are many options available for using to convert DICOM to STL. We're going to talk about each one of these. First and foremost, the Osirix software is a free open source software. It is fully featured, it has a ton of documentation, and is well accepted in the medical community. And it does not have any sort of click fees to be able to export STL files from DICOM. However, it is Macintosh only, and it is an extremely challenging to use software. Very cumbersome. Additionally, there is a paid version, In this software, it will yell at you and say that this is not an approved FDA-approved material and method for generating STL files and to use them in medical modeling. However, if you pay for this software, then all of a sudden it is FDA approved. The Blue Sky Plan software is an extremely wonderful software package. It's free, fully featured, has excellent support, incredibly simple operation, and allows you to export STL files of medical models and dental surgical guides, and additionally, dental models. However, there is a click fee or an export fee. Anytime that you want to export data from this software, you have to pay $10 to $20 per patient file. So, if you want to export a mandible or a maxilla from a patient's cone beam scan, you don't need to pay $10 to $20 per export, but you just pay $10 to $20 per patient. So you can export as many files from an individual patient as you like after you pay the initial fee. It does, however, have limited thresholding controls, and some would consider it a little bit cumbersome for thresholding, meaning changing the density of the medical model. One software that's really exciting is the Invisalia software. It's free and open source. It allows for exporting of any medical dental model easily with STL file format. There are no fees whatsoever. However, it is a relatively tricky software because there is no support. It's essentially an open source project in a Brazilian company. It's in collaboration with a variety of different open source programmers. However, there is some support out there, it's just not readily available. And it does have relatively cumbersome controls. It's not a wizard-based function. There is no step 1 to 2 to 3 to 4. You kind of have to just more or less figure it out. The CBCT acquisition software. Many cone beam machines allow you to directly export STL files from your cone beam scanner. This is included with your cone beam machine, and you can export any sort of file you want with this. There are no click fees traditionally, and there's also a little bit of a challenge to use here because it does not allow you to change the density or the thresholding of these images. Additionally, there is limited documentation and support from these companies.
Let's go ahead and install the Invisalia software to convert DICOM into STL. Open up any web browser that you have available and come into your search box and type in Invisalius. The first thing that comes up is a Brazilian website. If I click this button, it'll come to this main page. When you come under here, or the download here at the top, you can click on the download button and it'll give you the options that are available to you, whether you're a PC, Mac, or even Linux user. Depending upon which version of Windows you have, most of you will be using either the 32 or 64-bit, but Mac users always use the 64-bit. I recommend the 64-bit version of Windows. You click that button and it will download. Follow the installation prompts, then you can go ahead and open up your software. Alternatively, since this can be sometimes a tricky software to download, I have attached the downloaded current version of Invisalius to this presentation. Once you've downloaded everything, follow the commands and prompts to install the software wherever you so choose to do so. let's go ahead and download the Blue Sky Plan software. First and foremost, we're going to open up a web browser and direct it to blueskybio.com. When we open up the basic homepage of the Blue Sky Bio website, we're going to see a bunch of implants and different things that we could purchase if we'd like to. And then also we're going to see our Blue Sky Plan treatment planning software down here. If I click on this button, it's going to bring up a screen of where I can do a variety of things. I want to go ahead and type download software, choose my version of Windows or Macintosh. What's important is that we have to choose the right version of Windows. So what I want you to do is just go on your Microsoft, your Windows version of your computer, and open up your control panel. I typically go and type in on the start screen control panel, and it's going to open up my control panel. When I do that, I click on my system button, and it's going to tell me what type of system that I have here. On my computer, I'm running a Windows 10 Home, Intel Core 7i7, 16 gigs of RAM, and 64-bit operating system. It's usually listed right here. Since I have a 64-bit version of my operating system, I'm going to click this button, and it's going to start to download once I go ahead and hit and accept the terms. After it's done downloading, I go through the installation prompts and install the Blue Sky Plan software. So after downloading this Invisalia software, I also have attached to this presentation the Dr. Shear's DICOM example zip file. Feel free and download that folder to your desktop, double click it to open it, and right click copy, right click paste on the desktop to create a DICOMs folder. Inside of the DICOMs folder on your desktop, you're going to see here is we have GS data, mandible data, and ST data. These are going to be all of our hands-on examples that I want you to be able to use and follow along with during this course. What we're going to do first and foremost is go ahead and open up the Invisalia software. The Invisalia software allows you to convert DICOM files to STL files with no charges, no fees, completely free software. How we use this software is it comes to a home screen when you first open it. Click on the Import DICOM Images folder. Navigate to where your DICOMs are stored, and we're going to just left click once on the mandible data folder, and we're going to hit the Select Folder button. It's going to import all of the 290 slices from this patient. I then just go ahead and click the Import button. I don't need to do anything here other than hit that button. And it's going to bring up a series of boxes. Now, many times it will just show up a little bit goofy at first. Come under here onto the left-hand side of the screen and drop this down and hit Bone Setting. Just by this simple setting, automatically configures the entire program for you. Essentially, what we're doing in this software is that any areas of this light green color is going to be the areas of what we call thresholding. As I take my wheel mouse and I roll up and down, and I use my right click up and down button, allows me to zoom and roll around on the screen. In the axial slice, sagittal coronal slices, it allows me to see the green outline, ensuring that my bone is completely outlined. Our primary focus is this mandibular bone. Where we see the mandibular bone, I want to see the green line coming all the way around. Now, this particular patient, we did a CBCT scan of her edentulous mandible with the denture in place. If I were to change this slider around back and forth, you can see I can change the slider from strong to normal. This is what's called thresholding. When we do this in our software, it allows us to bring in things that may or may not be there. This would be an example of over-thresholding. I'm picking up a lot of fuzz around the outside portion. If I wanted to threshold all the way, I could then see all of the soft tissues, the cheeks, the face, and as I come up all the way up to here, here's the chin and the chin cup of the cone beam scan, or right up in here, this is the patient's nostrils. We don't want that. Just click this box and bone. That will do most of the settings for you. If you wanted to tweak it just a little bit, you can maybe just drag your slider around just to ensure that you've got all of the top portion of the bone enabled. But I encourage you, the vast majority of the time, all you need to do is hit bone. Now, what you do is you hit this Create Surface button. It's going to give you a three-dimensional output down here on the right-hand side of the screen. Now, it can take a significant amount of time while it does this, depending upon your computer and your computer hardware. Now my Invaselius program has completed the thresholding. Shown here in the bottom right-hand side of the screen is my patient's three-dimensional model completely digitized. This one I'm pretty pleased with. It looks pretty nice, pretty clean. If I'm a little bit concerned about not having as much surface up here on the top, that's because my bone density is a little bit lower right here at the crest, corresponding to where these green outlines are here. If I am not pleased with how that looks, I come back one step, click on this drop-down box right here, select region of interest, and now what I'm going to do is drag this slider across just ever so slight, and I'm going to hit the Create Service button again, which is going to make a second mask or data folder. So I'm going to do that just to show you as an example. Now my Invaselius software has created a second model on top of my original model. Now looking right here, I can maximize this just to visually see everything before I export these files. Now, what you'll notice down here in the bottom left-hand category is this data folder with your 3D surfaces. My first one versus my second one. And you can see here is that the volumetric difference between those two is significant, almost 40,000 units, which is millimeter cubed if I'm not mistaken. Yes. Now, if I turn off my original scan, this is what my secondary scan here looks like. The superior portion of the mandible is much nicer. Clean, evenly across. Now the only caveat too is you start to pick up some of this fuzz. Right down in here is some fuzz. All along here is fuzz. Depending upon what your desires are and what you want to do with this model, I'll show you the comparison of that versus my original. This is the original scan based upon just the bone setting in the Invaselius software. I much prefer this mode just because it creates a very nice clean mandible. Comparing that with this. Now if you don't mind going in and doing some smoothing and some shaping within Mesh Mixer, this is a much cleaner top portion of the mandible. If you want to fit for surgical guides or if you want to do this as a part of an educational training, I don't mind doing a little bit of smoothing over in here. However, the default setting allows you to do the vast majority of what you want to do with it. You'll just have a little bit of bone opening spaces right over in here. Just gives you an example of the dynamic nature of thresholding controls within the Invaselius software and all cone beam CTs. Now draw your attention also to the maxillary arch. So part of the reason why maxillary arches are challenging to get surgical guides to fit is you'll notice if I turn on and off my second scan over my first scan, that's a huge difference of how a surgical guide could potentially fit versus here versus here. Thresholding of the maxillary arch is significantly more challenging than the mandibular arch. As you noticed just before a few moments ago, getting that control for this mandibular bone, because it's such a dense cortical bone, while there's some changes between these two, it's not that significant. It just creates a little bit of a contour change. But watch on the maxilla as I turn it on and off, on and off. If you made a surgical guide fit on this first scan, then the bone in the mouth is really this large. The surgical guide won't fit. If you made it on this second scan and the bone was really like how it is here on scan number 1, then you'll have too sloppy of a fit of a guide. It'll fit loose. That's the challenges of thresholding control in any sort of medical or dental imaging. But the primary focus for many people within dentistry and medicine is this mandible. So I'm going to go ahead and then export this mandible as an STL file. Coming back to this mode here, I'm going to click and just delete surface number 2 just to make sure I don't accidentally export that. Now, I check my transparency. Everything here looks good. If I wanted to change the color, I could, but it won't export the color. It's just for the invis-alias. I hit next. Now, export 3D surface. I just click that button. Mandibular data, let's just call it patient.stl, and save. Now I should be able to import this into my Mesh Mixer software. We're going to demonstrate how to utilize Blue Sky Plan to convert DICOM data into STL files. First and foremost, we can double-click Blue Sky Plan and open up our main screen. When the Blue Sky Plan opens up to the main screen, it's going to look something similar to what you see in front of you. Everything pretty much blank. But it looks like a standard radiographic interpretation software, but that's where the differences there end. It's an incredibly powerful software for medical modeling. How we import our DICOM dataset is as we click on the File, New Project button. When we do that, I'm going to open up the folder of where my mandibular data is and click the OK button. The software is going to process this data. It's going to have your patient name here, the date of the scan, and then also all of the image data. Typically on this screen, we just hit the OK button. Now when we get to this screen, one of the nice features of this software versus the invis-alias software is we can limit the amount of information that we're going to interpret. If I grab this slider here, and here, it's going to limit the amount of data that I input. I'm going to typically try to just capture just past the condylar head. I'm going to put that one back up tall. It looks like I just barely captured the condyle. But all of this cranial base and vertebral column back in here I don't need. Then I click the OK button, and it's going to give me a direct visual assessment of the three-dimensional nature of how the software interprets the DICOM data. Now, of course, we can go in here and just look at all of the data sets by using our mouse wheel and rolling around different parts of the screen. We can always change our panoramic curve, do the things that we would normally do in a dental application. However, we're not going to be doing that here. All we're going to be doing is extracting the STL data from this patient. How we do that is I'm going to maximize this screen. So there's a little button here at the top right portion of the bottom left hand panel. I click on that button. I want it to be as large as possible while I visually see this. Now this software is pretty simple because all you have down here is this little slider down here at the bottom. And this is allowing you to control all of your thresholding features within your medical CT or dental combium data. Now what I want to do is bring this slider across until I just don't barely see some of this fuzz over in here. This fuzz is a lot of anatomical structures, soft tissue, muscle, fibers, ligaments, etc. I want to be able to capture as much of the bone as possible. not here. This is missing a lot of bone. Not here. I'm picking up too much fuzz. But right about there. I have just a little tiny bit of fuzz right there. And then all of this is looking nice and clean. Now you can spend quite a bit of time making sure you have exactly the thresholding that you desire. But right about here is ideal for me. I want to see the mental foramen nice and clean. My alveolar bone is well healed, not full of holes. And you can move around and see all of the other pertinent structures. Now what we're going to do is we're going to just simply come up to the File, Export Data folder. When we click on that, it's going to tell us our export data, if we have any, if we want to export as high, very high, or standard. Typically I click on the high button, and I want to make sure that nothing else in all of these boxes is selected except for CT data original checkbox. I'm going to click the export button. Now, if you don't see any of this export data, this does not pop up at all. It's because you'll need to purchase some export licenses from Blue Sky Bio. You can do that utilizing the Blue Sky Bio website or within the software. When I click the export button, it's going to ask me where I want to export everything to, and I'm going to call it BSP patient, and I click this export button, and it's going to reconstruct my data. Now in mine, I'm going to call mine 2 because I've already exported 1. When I click this button, it's going to take away one of my export licenses. When I do that, once I've locked it in for this Blue Sky Bio file, every time I export additional images out of that file, it does not take away one of your export licenses. So it's a really nice feature within Blue Sky Bio software. When I hit the Save button, it's going to create a surface model and do all the rendering that it needs to do. This video is going to be showing you how to export the DICOM as STL using your built-in acquisition software. This particular software has a native export to STL feature. You click on the drop-down box, choose the folder, and then type in whatever file name you would like for it. This particular software has this function built in, and there are additional other Cone Beam softwares that have this feature built in. While not as powerful as the other softwares, it gives you some basic functionality to pull up the STL file like shown here. I'm ready to open up my Mesh Mixer software and import my patient's DICOM turned into STL of their mandible. So under my DICOMs folder, I can open that back up to my mandibular data folder, and if I scroll all the way down, my STL file will be at the bottom. Left click, hold, and drag onto my Mesh Mixer software. After it's done importing, you might notice that this file is going to be very large for you to work with. Your computer also might slow down a little bit initially while working with it. This is to be expected with large medical models. Now, we have a mandible plus all of the other anatomical structures within our cone beam CT data. The first thing we want to do is we want to extract a lot of this other information and just delete it from the scene. So what I like to do is come up from underneath, hold my S button to select, left click, and then just start selecting everything in the cranial base that we don't need. Now that it's selected, I just hit the X button to clean it away. Continuing on in different orientations, I'll clean up here the inferior portion. X on your keyboard, and then the same thing from the frontal. X to cut it away. And now just changing your angle around just to cut away all of the structures you don't want. And the condylar head. And the condylar head back here. Now, as we do this, it's also important to note that this patient was biting down on cotton rolls with the mandible fully seated. If I was paying special attention to that structure, if I want to isolate the mandibular condylar head so that way I can analyze that and visually see it very cleanly, I'd want the patient to go ahead and be in protrusive. When I have the patient with their jaw forward, it removes the mandible from the mandibular socket and from the position of normal resting position. By translating anteriorly, it's going to put the head of the condyle on the disc soft tissue separation and away from the temporal bone. By doing that, it allows me to very easily isolate the segment within the software. Now I've got everything pretty much cleaned up within my scan. What I need to do now is this analysis and inspector button. And unfortunately, there's not a whole easy way to do this. You'll notice that this looks very complicated. But the nice thing about this versus my other models is I can hit this auto repair all button and let it do its work. By doing that, it essentially fixed everything for me. You can't do that on the dental model side because it'll fill in the base of the dental model and that won't work. Now we have a mandible that I can inspect her one more time just to make sure nothing comes up and hit done. This mandible is ready for 3D printing. So now I can export this as an STL file. File, export, DICOMs, mandible data, patient, man, print. And we can bring that into our 3D printing software. Now we can open up our preform software and import our mandible into the 3D printing platform. I like to print my mandibles also using the gray resin at 0.1 millimeter resolution. Opening up my DICOMS folder, my mandibular data, I can open up my patient man print, left click, hold and drag onto my preform software. It's then going to load our mandible onto the print platform. What I want to do now is determine the best orientation for how I want my mandible to print. I typically like to have my mandible pretty even with the anterior bone facing up as much as possible. So I would actually probably want to orient just a little bit like that right there. Now if you want faster print speeds, you can orient this way. The only challenge with that is that I typically use these mandibular models to print, so that way we can learn how to do implant surgery here on the anterior mandible. Now to do that, I'd want it at this orientation because that's how the patient is going to be opening and closing during surgery. So since I'm now printing a 360-degree object, something that has surfaces all the way around, I can't print directly on the print platform. If I tried to do my traditional method by selecting the base and clicking here, it's going to give me a funny effect like that. So I'm going to hit Control Z to undo that. What I want is I want it to be able to print just like this. So I'm going to hit this button right here that says Supports. And now under the Supports, I'm going to leave everything default and hit the Generate Selected button. And when it does that, it's going to automatically figure out everything here for me. I recommend automatic functions, especially while getting started, because you'll ensure that you get prints every time. As you start to play with the software and learn it a little bit more and feel comfortable with it, you can start generating these by yourself. Now the preform software has generated all of my supports for me. I'm going to shrink that away so I can analyze my supports a little bit better. Looking here at my 3D print, this would be an acceptable print for me. The entire anterior mandible is clear. The only thing I would potentially want to change is some of these areas back up in here. Why? Because typically I want to be doing implant surgery down here on the lower anterior mandible. Now, what we're going to do here is learn how to edit some of these supports. Under this button, if I hit the Edit button, it brings up this visualization. Any point that I click is going to allow me to turn on or off additional supports. So if I left click on these little blue orbs, when it turns orange, it'll remove them. If I hit the Apply Support Edits button, now they're going to be gone from right there. Then I make a decision, do I need less or more supports? Typically the reason why we do these supports in these softwares is so that way the prints, when they're facing these little overhanged areas, print better when you have a little piece of the resin bonding onto each other. But since in dentistry we're working with a lot of solid models, many times we don't need as many supports in different places. Now there is also occasionally supports that might be coming out on top and internally within the structures. But across the board that looks pretty good. There's one right there I might want to get rid of. Right there. And now we're complete with our support edits. Looking at our mandible all the way around, I can see I've got very nice supports everywhere. This mandible will print just fine. Looking at it from a three-dimensional view, I can see that this is the acceptable configuration for me. And keep in mind that this will take a significant amount of time for this to print. In case you were wondering, if you ever hit this print time button with this little arrow, it will calculate your print time. So now that the print time calculation is complete, it's estimating about 4 hours and 41 minutes for this to print completely. The nice thing is that you should be able to fit two of these onto a print at a time. Let's take a look to see if we can do that. If I take and I hit the duplicate button, that should not be a problem. Now we can fit two mandibles, full-size mandibles, onto a 3D printing platform at a time. This has been effective for me as we teach courses on how to work with implants and different aspects within implant dentistry, but the educational models of this are really, really fantastic. Now, one thing also I want to show you with this is occasionally you'll see some of these support structures inside of my mandible, like right here. One additional features of your support functions within the software is if you come under the support buttons, there is a checkbox down here for internal supports. If I uncheck that and then hit the Generate Selected button, it will redo my supports, but not having any supports inside of the actual mandible. That could be beneficial to our treatment here, since we're going to be using this for implant surgical application. Now that the support edits have been completed, you'll see internally, especially within our foramen, there are no longer supports in there. Looking at it from the back side, none of my other supports have changed, only removing the internal supports. Now you can see some of the challenges, though, of removing some of the internal supports is that we might have an unsupported area, which is this red area out in here. So sometimes I might want to add a couple of these little spheres just to see if I can get those to add some additional supports in there. And it won't do that there just because of the angle of the mandible. Say I did want to add an additional support right here. If I hit the edit button, click a few times here, create new blue orbs, now I have additional supports there. This is a trial and error process just to make a decision about what works the best. But the good news is that the preform software, the generate all or just the automatic functions are very, very beneficial. As I take my slider, I can then come through here and get an assessment of what my layers are, and you can visually see how it's going to build your mandible. Looking here in the mandibular anterior area, it allows us to visually see the internal structures of our anterior mandible. Inside of here is a lot of the medullary structure that was picked up in threshold and controls. As I go up a little bit, you'll see areas that are building onto the ridge and sliding all the way across until it's fully built. Typically, in my experience, these take somewhere between 4 and 6 hours for each mandible to print, hence why I put 2 of them on there, because that way I can maximize my printer time. Once satisfied with the layout and positioning of this, I feel pretty good about it. If I wanted to move just the one mandible here to the center, you can do that. Anytime that you do the support generation features within the preform software, it automatically puts it on the base, so you don't need to worry about orienting to the base like on the dental models. Once satisfied, click your print button and it prints. As I go ahead and I click the print command under the preform software, it pops up a dialog box of my printer, the installed resin cartridge, and tank. I click the OK button. These files with medical modeling take a lot longer to upload because of their size and also the print volume attached. It typically takes several minutes for one of these to upload. During that time, the printer is calculating all of the individual layers that it needs to project onto the laser and the resin. When the Print Now dialog appears, click that, and it will prompt you to ask to ensure that several of the features are correctly established. Once you've done that, click the Confirm button, the large circular button on the front of the printer. After my mandible is done printing, I'm going to open up the lid of my 3D printer, unlatch the build platform, and remove the mandible. Closing the lid and latch is going to ensure that my resin that's left inside of the printer remains fresh and not exposed to light. I set my build platform on a flat surface such as this lab bench. I can remove the mandible using a model removing tool. This little tool is meant to go underneath the edges of the supports and to gently twist. You don't want to go too fast with this procedure. Slow and steady wins the race. You can also use your spatula to gently pry it off. Once separated, I can inspect my mandible and make sure that everything printed correctly. Once I'm satisfied, I can take my mandible and place it into my left side finishing tank with isopropyl alcohol. I grab a C-fold or multi-fold towel and wipe down my entire build platform. It's important not to use any sort of isopropyl alcohol on the build platform, as it may contaminate the resin tank. Opening the lid of my 3D printer and replacing my build platform will ensure that everything is ready for my next print. After 5 minutes of soaking in the left tank, I gently agitate my basket with my mandible in place and transfer to the right tank. Both tanks have an equal amount of 91% isopropyl alcohol. I find effective is to flip the mandible on the side and gently agitating. After 5 minutes of additional soak in the right-hand tank, I'm going to gently remove my mandible from the tank. I'm going to place it on my countertop, and I'm going to grab my squeeze bottle with additional isopropyl alcohol in place. I then like to go ahead and spray the interior portions of my medical model in places of bone cavities, nerves, anything that may have an internal structure. That will help clean all of those nooks and crannies present in your medical model. Setting my medical model on the countertop will allow me to inspect it and to prepare to remove any of the supports. To remove the supports, I use my model nippers. The support removal nippers easily make short work out of grabbing and trimming off any of the areas of support. I start on the areas that are around some of the weakest structures, such as the coronoid and condyloid processes. Then I work my way down. As I go down, I can easily start to then just gently twist and start prying the mandible away from the support structures. With gentle motions, I can then just gentle hand manipulation until all the supports become weak and start tearing apart from the rest of the model. As I continue to use my support remover, you can see that I'm carefully and judiciously choosing where I'm nipping at every time. As I start to do that, I start to feel the weakness of the supports give way, and then I can put a little bit more force on the supports. As I do that, it reaches a point where then it just tears away clean from the model. It's important in extremely fragile prints, like on maxillary arches or on other body parts, that you're especially careful with the support removal. Additionally, in the Formlabs finishing kit, there are small tweezers and little delicate instruments that you can use to help with this process.
So we're going to take our mandible and we're going to do any sort of final polishing procedures to remove all of the support mechanisms from underneath. I like to take just any sort of standard acrylic burr lab handpiece, and I'm going to take a red striped fine acrylic adjusting instrument. And I'm going to zoom in a little bit so you have the opportunity to see how it's going to trim easily. If I take this on a moderate speed, I'm just going to lightly dust all of the areas of supports away. By doing so, is going to make for a very nice polished print. Now, alternatively, instead of using an acrylic burr, you can also use one of these blue points available from any of the burr companies. They're essentially a denture or acrylic adjusting point, almost like a rubber wheel, but in point form. I'm going to take that and just kind of rub all the way down and around in the areas of where my supports are. Now, with a little air, you'll see a much smoother appearance on the right-hand side than on the left-hand side. Continuing on, one additional way that I can do this is with a Burlue wheel. Burlue wheels is exceptional for finishing any sort of fine detail work without taking away a lot of the larger components. So hitting just each one of those supports is going to ensure that I have minimum change of my 3D printed mandible. Now, if I wanted to, I can also take a rag wheel to this and a fine adjusting a wheel underneath with pumice or resilience. But right now we have our 3D printed part, in this case a mandible, all completed.
In this video, I'm going to demonstrate using cone beam machine how to scan your dental model. In my cone beam software, I'm setting the parameters of the field of view, small voxel size, and also the quality as being high. I then hit the confirm button. When I hit the confirm button, it goes ahead and it sets my cone beam machine to start initializing. Your cone beam machine will go through a series of initialization movements, and during this time, stay away from the machine. Once it's completed, I take a styrofoam plate or a styrofoam square and put it directly on top of my panoramic or chin cup. I then place the dental model as if the patient were sitting in the cone beam machine, aligning using the midline and the normal canine position to facilitate the scan of the model. Now typically I like to put the center of the model right at that horizontal line. Once that's been complete, I then step outside of the room and start activating the cone beam machine. As I'm holding down the button, the cone beam machine is capturing the images as shown here on the bottom right hand side. The machine will spin around, scanning the model multiple times, and these multiple times will generate individual slices. These individual slices will help reconstruct the image in 3 dimensions. As the cone beam scanner spins around, it's important just to kind of give it some space and to keep outside of the room. The machine will tell you when it's done. When it's done, you can let go of the button and step back into the room. During this time, your machine will continue to spin. After it's done spinning, I can step in, remove the model and the styrofoam, and place the styrofoam back in its place as well as the chin cup and the bite fork. During this time, the cone beam software is going to reconstruct the DICOM data files. After reconstructing, it's going to convert into DICOM file format, and then it's going to pop up the images up on the screen where you can use your mouse and slide through to verify that you've captured the model completely. After doing so, it's going to open up the proprietary software that comes with the cone beam machine. I can then come up to the Tools Export function. In my particular software, it allows me to export STL files directly from the cone beam software. I then choose a folder, export this as a direct STL file. And I'll call it model. Once exported, I click the OK button. I then want to go ahead and export just the DICOM data files. I click on File, Export, Memory, and I'm going to navigate back to the desktop or into any particular folder I want to export my DICOM data set to. When I type in the name, I typically type in DICOMs, click OK, and it will export the DICOM data set for me. After complete, the DICOM data set is now stored in the computer, and I can close and log out of my software. I'm going to demonstrate how to convert my patient's DICOM data set of the cone beam of the model into STL. I'm going to do that with two methods, one with the Invisalia software and one with the Blue Sky Plan software. Attached to this presentation is the model scan zip file. Inside of there is a model folder with a DICOM folder that has the DICOM data, as well as the STL file automatically outputted from my cone beam scanner software. First and foremost, let's go ahead and open up our Invisalia software. When I do that, I click on the File, Import DICOM folder, and then I'm going to go ahead and navigate to my desktop. As I navigate to my desktop, I open up the Model Scan folder, Model, and the DICOM folder. I just go ahead and select that folder. Don't double click, just click Select Folder. The software is going to import all of the DICOM data slices from my patient's model. After importing, go ahead and click the Import button, and the software is going to render it. While you might not see anything in this screen, make sure you come under here and click on Bone. When you do that, the models will automatically appear in your sagittal, axial, and coronal slices. What I like to do is I like to use my right mouse clicker to zoom in on my model in quite detail. Many times I can use my wheel mouse on my center button and just start wheeling across until I start to see the cusp tips of my teeth. Sliding all the way through, I'm going to verify that the outline form of my model is completely green. As I toggle this back and forth, it will allow me to generate everything from scatter to insufficient model. I like to be just at that precipice point of looking right down in here into the vestibular form, of being too much versus too little. I'm about right there is ideal. Sliding through, looking at my cusp tips to make sure that I have all of the fine detail of my cusp tips in green. Once I get to that point, I go ahead and click the Create Surface button and let the Invisalia software generate a three-dimensional rendering in the bottom right-hand side of the screen. After the Invisalia software has generated a three-dimensional rendering, I can verify that it appears to be correct, using my right mouse clicker to zoom in and out, my left mouse clicker to rotate the screen around. Overall, I'm pretty satisfied with how that model looks. Then I click the Next Step button and come to where it says Export 3D Surfaces, and I just click somewhere where it says Export. I'm going to go ahead to that same folder, the DICOM folder, and I'm going to type in Model, DICOM, STL. I'll just say Scan. Now I've successfully outputted my STL file based upon a cone beam scan of my patient's model. The secondary approach is to go ahead and use the Blue Sky Plan software to do the same. The most effective way in the Blue Sky Plan software to do this is to go ahead and import the patient's DICOM files. I'm going to come under my desktop to my DICOMs folder, and I'm going to pull in my NP data folder, which is the patient that the model corresponds to. I click the OK button to start importing the patient's DICOM dataset into Blue Sky Bio. I then click the OK button and reorient according to the occlusal plane. That appears good. Then I click OK. The Blue Sky Plan software will import my patient's DICOMs and show me my three-dimensional rendering of my patient CBCT scan here in the bottom left. Just like I showed before, with this software, we go ahead and click on File, Import DICOMs, and click on Model Scan. It's then going to switch into a wizard mode. In the wizard mode, I then come back under my, not DICOMs folder, but my Model Scan folder, click on Model, and then click my DICOM data folder set. I'm going to click OK, and then the software is going to take me through the wizard function of creating a STL file out of this DICOM data. I click OK, and the Blue Sky Plan software is going to give me a visual rendering instantly of what the DICOM data set looks like. Most of the time it's pretty automatic and you don't need to do much to it at this point. But if I wanted to play with what's called the thresholding controls, this little slider that's down here on the bottom is going to change the scan ever so slightly. Because it appears right here on the default scan, I had a little fuzz at the palette. As I do that and come across, looking at the palette and then especially in the vestibule area, right about there is ideal. I then click the Next button, and it's going to create a surface model for me. Once the software generates a surface model based upon the DICOM dataset, I can then do my registration according to the Blue Sky Plan instructions we will be covering in a later section. I can go ahead for this exercise, just click on this Cancel Wizard button. If I wanted to, I could then just export this model by itself, turning off my CT surface under my Panels Surfaces tab. I can come up here to File, Export Data, ensure that the model scan here is checked and nothing else in all of the other boxes is checked off, and then click the Export button to go ahead and save it to a folder. After doing that, you'll have in your Files folder an STL folder where you can go ahead and bring up in any software and plan accordingly.
I'm going to demonstrate utilizing my CBCT scanner to scan denture teeth. As we've demonstrated before, we can utilize our intraoral scanner to digitize an STL file of a denture tooth. But you can also scan a denture card, bring into your InVisalius software, change the thresholding or the density values, and then generate a surface rendering of that file. I can then export that as an STL file, bring it into Mesh Mixer, and I can carefully section out each of those individual teeth from the tooth card using my Select tool and then my Translate function, cutting away any of the excess, and then the Repair function of the Analysis Inspector within Mesh Mixer. A really cool feature that many people just don't know that you can do with a cone beam scanner. Taking the cone beam scan, importing the DICOM files into InVisalius or into Blue Sky Plan software or Cyrix, you can then export an STL file and then work conventionally within MeshMixer. Course so far, let's have a little bit of fun with our CBCT scanner.
We're going to have a little bit of fun here for a moment. What's really cool about some of the cone beam things that you can do with this Invisilia software is that if I wanted to go ahead and import a DICOM data folder, you can also do some incredibly creative things. So by using your cone beam scanner, I could scan in random shapes or toys, depending upon what I decide to use. Looking at this clearly looks like the outline of a rubber ducky, and that is absolutely the case. I took a rubber ducky into my cone beam scanner, then visually assessed all of the dimensions of the rubber ducky, and create the surface. And we'll see what comes out. And just like magic, using Invisilia, you can scan any object, so long as it doesn't have a lot of metal scatter inside of it, and use that to generate an STL file. Now at this step, I can go next, export 3D surface. I'll just export it to here. We can minimize that, bring up our MeshMixer software, and it might tell me, yep, don't restore. Import. Let's go ahead and bring up our DICOMs, and I have it in a slightly different folder, just one moment. And find the folder, drag and drop to your MeshMixer software, and magically I have my rubber duck in MeshMixer, where I can now do whatever I wanted to do with it. I could sculpt it, I could change some of the shapes and contours if I wanted to make the hat taller, make the eyes bulge out, or something very, very crazy and creative, increase the lengths of these tail feathers, or even just for fun, work with him just like how he is. Then within my software, I can 3D print this rubber duck and give it away as a little toy or fun for kids in the practice or family members for the holidays and just different things. Keep in mind that also Formlabs does have a flexible resin where you could print this in a resin that actually will allow you to squeeze the rubber duck. Now the color of the flexible resin isn't very attractive. You can always take some spray paint to it and colorize it if you really wanted to do all that. But it's just fun for me. I can see here within the software that it gives you maximum versatility and flexibility. The possibilities of using cone beam CT data DICOM folders with the Invisilia software to be able to do some really creative things is amazing. In this video, I'm going to show you a cone beam scan of a ski boot. First and foremost, let's go ahead and open up our MeshMixer software. In my folder, I have a few STL files of different things that I worked on with this patient. The raw image out of my cone beam scanner, after processing with Invisilia, looks like this. You can see here I've got the chin cup and then the part of the ski boot. What's not shown here is the foam. Because of such low density, it won't show up. Using my S key on my keyboard and left clicking, I can select the chin cup, hit the X button on my keyboard and eliminate the chin cup and leave just the ski boot attached. Now using some of my sculpting tools, I can go ahead and slightly inflate these different areas and shrink smooth to get it to blend together. And I'm going to run my blending tool over the entire bottom portion of the ski boot. And if you take a look over here at the strength and size functions, it's important to be cognizant of that because you don't want to alter the important geometry of this ski boot part like I just did there. I find it easier just to kind of smooth things across and to remove all of your cone beam radiation marks. All of these sand dune style waves are from the cone beam machine, and those are individual X-ray slices. Also stay away from the detail part of this. You don't want to shrink all of that in there like I just did. You want to leave that alone. Same thing here on the underneath side. You want to leave most of this geometry alone. Now, a couple of things that this patient wished me to do is just try to fix some of this slope. And I don't know if I'll necessarily be able to do that now, but if you wanted to, you could do that with the draw tool and slowly but surely draw this out until you're at the thickness you desire. Anytime that I use this draw tool, I'm also going to go back in with a shrink smooth tool so that way I can blend it all together. But you're kind of getting the idea there. Now I come in with my shrink smooth tool and just blend it all together. Now we're ready to go ahead and export this. If I hit File, Export, and I'm going to go ahead and pull that up on my desktop to the boot folder, and I've already saved one as boot final. So now bringing up my preform software, I can take my software and then open up my boot folder and drag my boot final. Now that it's in the software, I can reorient the boot part and find the best way to print it. Which we know we want to be careful with how it's positioned. I want to create it as vertical as possible, turn off any of the internal supports, and I'm going to go ahead and click the Generate Selected button for the supports. As I do that, that's a pretty good clean print. I'd be able to easily clean that up. Now I can go ahead and hit the print button.
And finally, when we go into sort of the last bit of fun stuff, we know that we can also do things with toys. If I have a patient of mine that's really into this cute little reindeer like we see here on the left-hand side of the screen, I can throw that into my cone beam machine, run a cone beam scan, and then duplicate it in this kind of grayish material. Is it perfect? No, of course not, but it allows you to do some really kind of fun and interesting things. Also, some more practical things for clinical dentistry. Many times I have my assistants that will work with these little parts and pieces in their cone beam scanner, this little bite fork in the panoramic machine, and they put a cover over it. They grab the cover off, and then the little bite fork comes with it, and they throw away one of these bite forks, and it's like $30 each time that they do that. I took one of those, put it into my cone beam machine, scanned it, and then I could duplicate it using my 3D printer. And finally, some last little bit of fun things that you can do with your 3D printer is this right here is a custom iPhone holder that I have in my practice. I literally use every day. My phone has a cradle where it snaps into. My phone cord plugs in right in here, and then it's actually got an embossed practice logo on it. We use this as the occasional giveaway for our patients too. Kind of makes for a really fun day at the office, and also, wow, we do some amazing things with dental and medical modeling and printing here.